Hello, and welcome to today's webinar on improving patient access to medicines through PBM reform. My name is Chuck Strand. I'm the Executive Director of Rural Minds, the only national nonprofit focused solely on providing the 46 million people living in rural America with free information and resources to confront rural mental health challenges and the stigma that surrounds mental illness. This includes a free online course for mental health awareness and suicide prevention in rural America developed by Cornell University's College of Veterinary Medicine and New York FarmNet in partnership with Rural Minds. The course just launched and can be accessed at ruralminds.org. We're very excited to present today's discussion along with the National Grange with sponsorship by Grange Advocacy. We appreciate our long-standing partnership with the National Grange as we work together to improve the state of mental health in rural communities across the country and address mental health in rural communities and inequity. Holistic health includes mental health, which is why the mental health crisis in rural America is a priority for both Grange and Rural Minds. During today's conversation, we'll learn more about pharmacy benefit managers, or PBMs. While some of us may not be familiar with PBMs, they play a significant role in how we get the medications we need. To start things off, we thought it would be helpful to share a video from the National Consumers League. But as an aside, we at Rural Minds and the Grange respect the privacy of everyone who's watching the webinar today. Know that your name and image will not be visible to others in the audience. Throughout the webinar, we invite you to enter any questions you may have in the Q&A field, and we will answer as many as possible during the Q&A session. Also, if at any time you or someone you know is experiencing a mental health crisis, call 988 to speak with a trained mental health counselor 24/7 at the National Suicide Prevention Lifeline. That number again is 988.
These middlemen corporations control more than 80% of the prescription drug formularies in the US, which means that they control which medicines your health insurance pays for and which ones they don't. PBMs effectively control how much you pay for your meds and, perhaps most importantly, why. Let's go back in time. The whole reason PBMs came into existence was to streamline how we get our medicines. They were meant to help drive savings for consumers, but they've lost their way. Today, they put profits before consumers. There are a few reasons this is happening. First, there are many behind-the-scenes PBM negotiations, price gouging practices, and complicated schemes that drive our costs up, putting all of us at an unfair disadvantage. PBMs have little accountability and no competition. Consider this. 3 major PBMs make up 75% of the market. This unspoken triopoly means that PBMs can easily manipulate the price and make it impossible for us to get a fair deal. Because PBMs decide what medicines we are eligible to get by controlling the lists of medicines covered by health plans, they steer consumers to drugs that give PBMs higher profit margins. The higher the price of a drug, the more money PBMs make. That's not right. PBMs negotiate with drug makers to figure out discounts on drugs. But instead of funneling these savings back to us, the consumers, they have gotten greedy. They now keep the rebates. In fact, a recent Senate Finance Committee report found that some PBMs are getting 70% rebates on insulin, while out-of-pocket costs for consumers continue to rise. And unless our elected officials take action, PBMs will continue taking advantage of us and exploit the system to increase their profits, while out-of-pocket costs will just go up and up. The next time you're at the pharmacy counter and notice that your costs keep going up, you might ask yourself, how much of this is going to PBMs? We want to address these issues. Join us as we fight unfair practices and put consumers first before the bottom lines of PBMs.
Now that we have a little more background on this important issue, we can dive into the conversation with today's panelists. Thank you for joining us today. I'll now turn it over to Jessica Frasco, who will be moderating today's discussion.
Thank you so much, Chuck. I am Jessica Frasco. I am from Heart Health Strategies, and I'm going to moderate today's conversation with our 2 incredible panelists who are joining us. We're joined today by Dr. Madelaine Feldman, a rheumatologist, and also by Alfred Pence, an independent pharmacist. Dr. Madelaine Feldman, would you like to introduce yourself to the group?
Sure. Hi, they call me Dr. Maddie. I actually used to have a radio show called Driving with Dr. Maddie. And I'm a rheumatologist, meaning I take care of people predominantly with what are known as inflammatory arthritis. But ultimately I see everything from tennis elbow to lupus, rheumatoid arthritis, psoriatic arthritis. I've been doing it now for almost 30 years. But additionally, I've become very active in the advocacy world, making sure that my patients can get access to the drugs that they need. And I've been doing that for over 10 years, maybe 15 years. So I'm so happy to be here with you and to maybe help you understand a little bit better about pharmacy benefit managers. Thank you.
Thank you so much. And Alfred, would you like to introduce yourself?
Sure. My name is Alfred Pence. I'm from a small community in rural Kentucky, at the center of Kentucky, actually. And I'm a community pharmacist. We do compounding and vaccinations and counseling patients, and just generally good pharmacy practice in a retail setting. I come from a long generation of pharmacists. My store has been here for over 100 years in the family, and I've been in practice for 55 years. And so I thank you for having me.
Thank you so much, Alfred. And I'm very excited to dive into today's conversation with you and with Dr. Maddie. Before we dive into that, I just want to make sure that everyone is aware that if you have any questions throughout today's conversation, we're going to save those until the end. You can use your chat function and submit questions for the Q&A, and we'll read those in about the last 15 minutes and present those to both Dr. Maddie and to Alfred for their feedback. So be sure to send those in. And on that note, I think we'll start with a question for you, Dr. Maddie. During this short video, we learned a lot about these middlemen, these pharmacy benefit managers, or today we're really going to refer to them as PBMs. And what we learned is that PBMs and not healthcare providers are dictating which medications patients have access to, which as a rheumatologist, I can only imagine how incredibly frustrating that must be. Can you just explain a little bit more how that happens?
It's extremely frustrating. You know, when I went out into practice in the early 90s, we didn't have that same kind of judicial preference by the insurance company as to what medication I could prescribe. But now what has happened, the pharmacy benefit managers control what is known as the formulary, and that's the list of drugs that they will pay for. Those are the drugs that you get at the pharmacy. They're different from the drugs like you would get infused or a shot in the doctor's office. That's controlled by a different part of the insurance company. But that entire list are the only drugs that I can prescribe. But unfortunately, not only do they tell me what drugs I can prescribe by choosing the ones for the formulary, they tell me when my patients can take them. They use something called, what they do is they manage the utilization of the drugs. And they do this by putting rules in place. They'll tell me, you have to use this drug first before you can use another drug. That's called step therapy. Or they tell me, I'm sorry, we don't cover that drug at all, in spite of the fact that that would be the one that works best for your patient. And that's called an exclusion. They exclude it from the formulary. And then the other thing they do is my patient it could be you, are stable on a particular medication for 3 or 4 years that took us a year to get you stable on. And then all of a sudden they go, oops, I'm sorry, your patient will now have to pay $500 for that drug. But this is the drug that we prefer that they use, and that's called non-medical switching. So they are able to control what drugs my patients can take, when they can take them, and ultimately how much they'll pay for them. Because there's a dirty little secret about how they pick the drugs that get onto the formulary. You'd think it was, oh, well, this must be the one that works the best. No, guess again. Well, this must be the drug that's the safest. No, guess again. Well, this must be the one with the lowest price. Unfortunately, guess again. How they choose which drugs and in which order you can take them is based on, and I'm just going to say it, how much money they can make on the drug. The manufacturers know that if their drug is not on the formulary and it's an expensive drug, no one's going to take it. So they have to bid against each other to the PBM, to the pharmacy benefit manager, to see who can get the best spot on the formulary. And guess what? Their bids are based on a percent of the list price of the drug. So just to give you an example to make it seem a little bit easier, if I'm a manufacturer and I have a $500 a month drug, my bid is that I tell the PBM, I'll give you 50% back every time you fill that script. And the PBM goes, that's $250, okay. And then the next manufacturer who makes maybe a different drug for that disease says, Mine's $1,000 a month and I'll give you 50% back. The PBM goes, well, that means I'd get $500. I'm going to pick the drug that's $1,000. So consequently, the competition to get on the formulary, like selling your house, the more people bidding, what happens to the price of your house? It goes up. The more manufacturers bidding to get that spot on the list of drugs that PBMs will pay for increases the price of the drug. So unfortunately, tells me when you can, what drug you can take, when you can take it, how much you're going to pay for it. And they also know, they can also determine where you're going to pick it up. And that's where the pharmacy comes in. And I'm going to let Alfred take over there because they determine what pharmacy and if you can even go to a community pharmacy. And that should not be either.
Well, Dr. Feldman, how frustrating is it to you when I have to call you to say, you don't get this drug, you can't have this drug for your patient? How much time does it take for you to get it approved? How much time does it cost your patients in time without therapy? And it's frustrating for me as a pharmacist because I have to call you. I have to sometimes send you forms to fill out. And so it's frustrating all the way around.
You send me the forms, I fill them out, and sometimes the insurance company still doesn't approve it.
That's
so
correct.
It costs, you're right, it absolutely costs my patients not only money, but it also costs them their health.
Right, exactly.
And I think they cost you your livelihood.
They are. They are. They are.
Truly, and Alfred, I'd love to talk more about that because, you know, our independent pharmacists are such an important part of our community. And for the folks on the call today, I'm sure many of you have your local pharmacy that's in your downtown and you've known your pharmacist for 20 years and they've been prescribing, you know, all of your family's medications. They know when your birthday is, they know all of the side effects that impact you. And independent pharmacists play such an essential role in our community. And the PBMs are making it really hard for these independent pharmacists to stay in, you know, to keep their doors open. And I was wondering if you could tell us a little bit more about your experience with these PBMs.
Sure. Well, first off, in my 55 years, we've never seen such low reimbursements. And that's a killer. And I'm suspecting that the first of the year, we're going to see even more lower reimbursements. But most people don't know that we have fees to pay. The Part D Medicare plans all have fees. And for instance, in 2023, in the first trimester, now we have to pay fees with some companies 3 times a year. In the first trimester, I had to pay one of the major PBMs about $30,000. Multiply that times 3, and you get about $90,000 in fees for that one PBM. Another one of the big PBMs charges me $4,500 a month. And it's very hard for us to make a living out of that much. It's just terrible. So another thing that is a problem for us is we don't know what they're charging. In other words, we may have 2 different insurance companies or 3 that charge totally different fees. And even within the insurance plans, there are different fees. So we're sort of out on the limb, have been up to this time, out on the limb, knowing how many fees we're going to have to pay. The first of this year, they have decided to go at the point of sale. So we know how much we're losing. We're not making. So that's the fees are something that most people do not know about. And we have mail order problems too. In the mail order industry is a big problem for us because some of the companies, PBMs, want us to use mail order, want the customers to use mail order. And they'll let us do maybe 2 prescriptions in a month, and then they have to go to mail order for their chronic medications.
And what they've told my patients out, you're exactly right.
Yeah.
Oftentimes they say, no, you don't have to use mail order, but if you don't use mail order, it's not what you pay for the drug isn't going to count towards your deductible.
That's
They
right.
use all kinds of things to, if they don't force you, they certainly incentivize patients to mail order. And you don't get to speak to those patients, do you?
No, no, as a matter of fact, one of the really big problems right now is our patients have not signed up for mail order and they've stolen my patients. And I have a patient that came in that just the other day that said, I need some of my, I think it was a blood pressure medicine. I said, okay, but I couldn't fill it because the mail order had already sent it to him. He said, I don't take mail order. I don't do mail order. He said, I said, well, they've sent it to you anyway. So he said, I'm going to straighten that out right now. So they're stealing our patients. They're not even asking anymore. So that's a really big problem, and we need to stop that.
So Alfred, just to make sure I'm understanding you correctly, it's not like you're getting to mail the medications to your patients so then they can come in and still ask you questions. Instead, these PBMs are really taking your patients away, removing that experience that they have with the pharmacist, and then you're left with no experience with that patient, right?
Right. But my regular patients that I have had all along, some of them will come in and say, I don't take mail order, but they've sent me mail order stuff. I don't want that. And so I tell them, you're going to have to call and cancel that mail order because
Sometimes
I
it's
can't fill your
difficult to
prescriptions
do.
now.
I've had patients bring me pictures of medications that had to be within a specific temperature range, and they were just left on their front porch in the middle of the summer. And obviously they may not be any good anymore, and
Right.
they're not replaced. Mandated mail order is
terrible.
bad, is very bad. And even if they don't mandate, like I said, they incentivize the patients by saying it's not going to count towards your deductible if you don't use our mail order. And they may not know the little things about the patient that you've known their whole life, in terms of maybe they don't have a real allergy, but they're intolerant to it. And, and if they, a lot of times, as you know, they switch manufacturers, and the patient, I'm sure, comes to you and says, well, my pill used to be pink and now it's blue. And you can explain it to them. But when it just shows up in the mail blue, my patients come to me and I go, that's your blood pressure medicine. I think it's probably because it's a different manufacturer. So it's mail order across the board, takes your patients away and is harmful to my patients.
Right. And another thing, I have no profiles on them with their mail order. So if they come to me for an acute medication, I'll not know unless they know the name of the drugs and stuff and they don't know, most of the patients don't. I won't know whether there's a drug interaction, what to warn them about, because they haven't taken their main medicines from me. So we're at a loss on that.
Al, I was told by a pharmacist friend of mine, and they said that a lot of those fees are based on if you follow their rules. But the problem is the pharmacists don't know what the rules are. And actually, one of them told me that if a patient stopped taking the medicine in the middle of the year, just didn't fill it anymore, that
Right.
they were actually dinged as if they had made a mistake. So these, patients, we stop patients' medications. What if they'd had an allergic reaction? What if it didn't work anymore? What if they were in the hospital? There's lots of reasons that have absolutely, in fact, most of them have absolutely nothing to do with the pharmacist. Is that true? Do you get dinged sometimes for weird things that nobody ever even told you about?
Oh, yes. They have a thing called star ratings, and I hate to get into the star ratings because it's a little bit complicated. But the fact is, if you have a patient that doesn't take, say you have a diabetic patient, there's a protocol for the diabetic patient, aspirins, ACE inhibitors, or something like that. And if you miss one of the protocols, like statins, they're supposed to take statins. A lot of my patients can't take statins, and we get dinged on that. It costs us in fees or non-payments whenever we don't have a patient that's taking their statins. And diabetics, things are the same way. If a doctor takes a patient off of something, it dings us because they haven't gotten it in the last 3 or 4 months. So it's a crazy system. It's a crazy.
Ridiculous. Yep.
So what I'm hearing from both of you, which is just so wild to me, is that these PBMs, which I'm sure most people today on this webinar had never even heard of before, but
Right.
these PBMs are playing doctor and pharmacist, but the patient has no relationship with this person who is playing doctor or pharmacist and no interaction with them, which is just so concerning to me. And as a patient, it's just, as somebody who takes prescribed medications, it's just, to know that somebody else other than my doctor or my pharmacist is making these decisions is really alarming.
Bizarre.
Dr. Feldman, I think, we've heard time and time again from these PBMs when they defend their practices that they're really responsible for a lot of healthcare savings. But I don't think the patients are seeing these supposed savings at the pharmacy counter. Why is that? And can we change that?
So this is how they define savings, and it's the same thing, which, if you had two cows that were exactly the same, and you were gonna buy one of these cows, and one was $1,000 and one was $2,000, and both of them were 50% off. Which one would you save more money on? Obviously, you'd save more money on the $2,000 a year or $2,000 cow. I'm sure cows cost a lot more than that. I have no idea, but you'd save $1,000, whereas on the cheaper cow, you only save 500. They never tell anyone that they're choosing the higher drug to get those savings. And then the really rich part is those savings are never passed down to the patient. I'm not sure who they're saving the money for. They say the healthcare system, but unfortunately, they are the healthcare system. These PBMs are now, they either own, as in the case of CVS, they own their own insurance company. They actually own Aetna. And CVS, actually, the pharmacy is not what made all the money for CVS. It was CVS Caremark, the PBM, and they managed to cobble together, I don't know, close to $90 billion to buy Aetna. So PBM is a very lucrative business. And then the other ones, Express Scripts, which in some cases is called Evernorth, is owned by Cigna. And then United Healthcare, the behemoth that pretty much they have their own bank, they have their own data system, they have their own, they own doctors. They have their own PBM, which is called OptumRx. So now you've got these three that control nearly 80% of all prescriptions, including Medicare. Basically, it's an oligopoly. It's three monopolies together, and they control it all. So you don't even have a choice. If you're a business person and you're self-insured, you've got these three big PBMs, and they pull the wool over the eyes. There was an example of, and the employees and my employees, I'm not self-funded, but we all have co-pays and co-insurances. And the co-insurance is usually 20% of the list price of the drug. And so if there's a $2,000 drug and I've got to pay 20% of it every month, until I meet my deductible, that's a lot of money out of my pocket. And oftentimes that $2,000 that they're charging the patient for the drug, they could have maybe found it somewhere else, but they don't tell anybody. They put these higher priced drugs there, and they don't even tell them that there's a generic. There was one example, and this included mental health drugs, although the particular example was for a prostate cancer drug that cost $10,000 a month. This was a couple years ago. And they called the PBM and said, look, there's a $300 generic. And the PBM pharmacy tech said, well, your insurance is only covering the $10,000 drug. Your employee will have to pay the full price, $350 for the generic, because it's not included on our formulary. And they said, well, wait, what do you mean? You're only preferring the brand drug? And they say, oh, we do that a lot, particularly with mental health drugs. And then they started to count off the different drugs which they would not cover the less expensive generic drug. They wouldn't even give the patient a choice. And it's all because back in the late 90s, the United States decided that it would be okay for PBMs to get kickbacks from the manufacturer to buy their way onto the formulary. I'm just using the terms that really that's what's happening. They gave them what's known as safe harbor protection from the anti-kickback statute. So it incentivizes PBMs in order to make more money. They choose these higher priced drugs. And and because there's so few of them, they pretty much control the entire market, and they can determine whether, you know, Al gets any business or not. And if he does, then they also determine that we can ding you for every little thing that we make up that we think might be worthwhile. So it's a very, very bad system. There's no innocence. It's not like just the PBMs are bad and the manufacturers don't have anything to do with it. But people wonder why in Europe the prices are so much lower for these drugs. There are no middlemen scarfing up all the savings from the manufacturers in Europe. There are no PBMs anywhere else in the world except here. I've heard Canada is thinking about putting some PBMs, and I would say, be careful what you wish for, because what's going to happen is the middleman is going to take up all the savings and claim they've got even greater and greater savings. I think at some point we can't afford that many savings. You know, I'd rather spend $200 and only save $100 than spend $2,000 and save $1,000, particularly when I'm not getting the savings. And that's what you see here in the United States. So there's lots of reasons why prices are high and lots of reasons, but the bottom line is the patient. The doctor-patient relationship no longer has any control over how to treat them. And when you say, "Oh, Mr. PBM, you're the doctor. You're acting as though you're the doctor in this, and you're deciding the prescriptions," and they go, "Oh, no, no, no. We're not deciding what the doctor could prescribe. They can prescribe anything they want. We just won't pay for them." And as we all know, drug prices are really high, and most of the time, if they're not covered by your insurance, many times you just don't have access to them. It's not a good system.
If you've noticed on the news that there's a committee that's been meeting and they have had the Novo manufacturing CEO, I think is CEO, that they were grilling about why the prices for Ozempic were so much higher in the US than they were anywhere else in the world. And they were questioning him about this. And when they talked to him about it, he said, "Well, it's your system of insurance and your PBMs that have made these prices high. They're using the list prices of the drugs without the rebates." So, and I thought maybe we might talk about some steering if you don't mind doing it.
Yeah, absolutely, Alfred, because I think, you know, Dr. Maddie's been really passionate about, you know, these three PBMs and that they take up 75 to 80% of the market. And if somebody is monopolizing 80% of the market, I can't even imagine what that does to a smaller independent pharmacist like you. How does that disproportionate share impact you?
But it's terrible. I have several people that I could have as patients that I can't have because they've been sent to or steered to one of these PBMs pharmacies. And right now, I have filled some prescriptions for some patients. They'll get, for the first two prescriptions, they can fill them at my store, but then they have to go to the PBM designated stores after that. And so, and I have some people who cannot shop with me anymore because the PBM has directed them to another store. And that's just terrible, because I can't treat my patients. They have been my patients all along, and they have to go now to the preferred pharmacy, whether it's a mail order or one of the three PBMs, the major PBMs, or
it's a pharmacy they own, like CVS, Caremark, CVS, they own all their own pharmacies.
Yeah, that's vertical integration. And I think you can talk about that one because vertical integration is an awful thing. But if you don't mind saying what vertical integration is at this point, maybe you can inform them about it.
That's when you have what I call the mothership, which is the health insurance company. We've always, the ones that pay when you go to the doctor, they pay when you go in the hospital, they pay if you get an infusion. United Healthcare is the great example because they've owned their own PBM for a long time. So they own the major healthcare, the health insurance. They own the pharmacy benefit, so they control the the formulary for the drugs you can get infused, then through the PBM, they control the formulary for the ones you pick up at the drugstore. Then they own the pharmacy. Then they own the specialty pharmacy. And specialty pharmacies are supposed to be for drugs, and Al could probably tell you more about this, that require certain kinds of handling. There's certain kinds of risks. They're higher risk. And the thing is, they often will call, and they tend to be more expensive. They will often designate a generic as a specialty drug in order to funnel it through their own specialty pharmacy, because all three own their own specialty pharmacy. And they charge more. And Al may get to, as he said, dispense 1 month or 2 months, but then it all has to go through their specialty pharmacy. And not only do they get the money that's paid for the dispensing of the drug and the value of the drug, but the manufacturers also have to pay the specialty pharmacy fees. Now that people have heard about rebates and are trying to get more transparency with how much these kickbacks are actually worth, the PBMs have decided to not call them rebates anymore. And now they call them fees. And in the contract with the manufacturer, the fees cannot be passed on to the client, and whether it's a patient or whether it's an employer. So every time we try to find some type of way to, piece of legislation, any kind of oversight of the PBMs, they find another way to hide the money. And they are very good at hiding the money.
They really are. Well, you might wonder, what's the importance of independent pharmacies in our rural communities? And I think we are very important because I do compounding. I have patients that I make specialty compounds for, seizure patients, patients who've had heart transplants. I've had compounding where we've had babies born to mothers that were addicted. We've had to go through that thing. We give lots of vaccinations now, and we're a part of the community. Our pharmacists are part of the community. We interact with the community. We care about our community. We care about the people in our community. And so I think it's very important that I hope it's very important to you that we continue to support our community pharmacists. When you're steered to a store, for example, my daughter could not get her vaccinations in my pharmacy because she was steered toward another PBM pharmacy. My pharmacist cannot get his prescriptions at my pharmacy where he's employed because he's on a plan with his wife and they're steered to a pharmacy that's 10 miles away. So, and the cost to the patient is not only just that, if they have to drive 10 or 20 miles to get their medicines, we're rural now. That's an expense in time and money for them to go to their community, through their community, to another community, and then back. So it's overall just a bad thing.
Alfred, how many times have you seen, because one of the other things they do and they put in the contracts is they can change the formulary, the list of drugs they'll pay for, like 6 times in 1 year, and not even tell the doctor nor the patient. There was that story of that young man, and I think it was in Florida. He went to go pick up his inhaler, and they had changed it to a higher tier without telling the patient, without telling the doctor. And now it was $250, I think, and he couldn't afford it. And so he left the pharmacy, and the next day he died of an asthma attack. And, the fact that they are able to do that without informing patients ahead of time is dangerous. It's totally dangerous. Between making patients, putting community pharmacists out of business, changing up the formularies. I mean, there are people, they did this with atrial fibrillation patients a couple years ago. They just stopped paying for the leading blood thinner and put them on a blood thinner that made them more money. And there were patients that had strokes. There were patients that had brain bleeds. There were patients that had blood clots because it didn't thin the blood enough with the atrial fibrillation. And they somehow get away with it. And they claim, and they sit in front of Congress saying that they're not putting community pharmacists out of business. I've heard there's lots of them going out of business. Isn't that the case?
That's very definitely the case. Yes. I mean, we can't make a living on what they're paying is 6.8% of my prescriptions last year were in the negative. I have one patient has a seizure problem, and his prescriptions cost $6,000 a month. It costs me $6,000 a month. And when I bill his insurance company, they only pay me 59, I think it's 59. Anyway, I lose $100 every month on that prescription. And how long can I keep that up? I don't know.
You can't. I have patients that there are certain medications that they can't find anywhere in the city because no pharmacist will carry it anymore because they're not paid enough. They're trying to do that now with rheumatologists in telling us you have to infuse this one particular drug. It doesn't come from PBMs, but you have to use this one, and we'd lose maybe $400 or $500 every time we did it. They can't expect, you know, independent practices and independent pharmacies to stay open. And it makes me wonder if this isn't the grand plan to begin with.
I think
if they want to drive, I know United Healthcare is buying up doctors, and I'm sure, you know, the big three would be happy to come and put a CVS, maybe, or maybe the people in your community just lose access altogether to a pharmacy.
Right.
Yeah, Alfred, this is so concerning. I mean, first you talked about kind of the excessive fees that they're charging and how untransparent those fees are, and then the steering and how they're driving your patients away, and now how the PBMs aren't even reimbursing you for the full amount that you need in order to dispense the medication. And because you're a good guy and because you care about your patients, you're still filling that prescription, right? Because other people would be like, well, I just wouldn't fill it. Well, where would, you know, Joey, who you've known since he was 10, where would he get that med? So this is just so upsetting to hear. And I can't even imagine, you know, how it would impact your community if you were unable to continue to provide these prescriptions. So thank you for continuing and for sharing these stories. I'm going to ask one more question, and then I think we're going to move into Q&A. And so if you do have a question and you haven't submitted it through the question and answer function, please do that now. We talked a little bit about all of the ways in which the system is really abusive, and how these PBMs, which a lot of us never even heard of before today, how they are really just like these actors in the dark of night who are really driving where patients are getting their prescriptions, what prescriptions they can get, where they can get them. Are there ways to fix this? Are there solutions that can make this better for patients so that, you know, they can sleep easier after today's conversation?
You know, the things like step therapy, you can go either through legislation where either a state or the federal government makes a law, or there are sort of what we call regulatory, where there can be agencies that can, you know, maybe the Department of Insurance can say you can't do this or you can't do that, but usually they like to have a law behind them. And around the country, you know, whether we partnered with the National Community Pharmacists Association, I do advocacy and government affairs in addition to private practice for a group called the Coalition of State Rheumatology Organizations. And we have helped pass with other organizations step therapy reform, where if a patient is stable, the insurance company has to continue paying for it. They can't, you know, maybe in another case, the law says you can't just switch the formulary, you know, more than once a year. I'd like it so that they can never switch the formulary, but more than once a year without telling the patient. So there are rules and laws. You know, what we'd like to see is all these rebates somehow getting passed back to the user, to the patient, preferably at the point of sale, where the patient actually gets to recoup all the savings that have been going to the PBM, you know, or, you know, in utopia, make the manufacturers bid on their lowest price and not on their highest kickback. That would fix it, but that ain't never gonna happen. And there's a lot out there that they're trying to help pharmacists, aren't there, Al, in terms of laws that we're trying to help get passed?
Yes, Congress has been looking at the main losers we have are the Medicare Part D, and Congress can fix that if they will. They can fix that by getting away the patient steering, greater transparency with what rebates are you giving to the patients rather than taking it yourself? And I think if people would just contact their senator or the representative and say, you need to protect us from the PBMs. I know that sounds crazy, but
It's true.
they need to know. They
It's
need to
true.
know
They need
that
to protect the pharmacists, they need to protect the patients, and in some cases, they need to protect the doctors, because, you know, many of them try to put us out of business as well.
that's
But the
right.
bottom line is, it's harming the patient. You know, a few years back, they tried to, have something that passed the rebates on to the patient at the point of sale,
Right.
and that got sort of tabled till later, and then later, and then later, and then that little package actually, because it saved money, was used to pay for infrastructure. So, you know, it's a very, very, our Congress and the laws that they pass and how they pick and choose which ones to pass, it's kind of over my head. You know, I'd say let's pick the ones that benefit the people the most. And unfortunately, that doesn't always happen.
You know, I would have to say there was one PBM that I didn't have a problem with. In the state of Kentucky, we have a Med Impact PBM, and the legislature has given us a fee that's a fair fee. And the PBM is saving the state of Kentucky money. It's paying us a fee that we can live with. I'm not saying it's the greatest fee in the world, but we're not losing. So we're grateful for every patient that the Kentucky State Legislature sent us. So that's the only PBM that I really like. But
And maybe it's because the state's making them be nice to you.
and you know what? The state is saving hundreds of millions of dollars by only doing that one PBM and setting the fee that they, and then they set a fee and they're paying us regularly on time.
Right. So education is needed. People need to understand, like today, what a pharmacy benefit manager is, how they directly affect your health. I mean, directly, they affect it. You know,
They
you can't
do.
get the medicine, you get sick, then you can't afford the medicine. And oftentimes the blame sits squarely on the pharmacy benefit manager. I mean,
Yes.
are there any, do people have questions about this? I feel like I'm wondering if people are understanding about what the PBMs are doing.
Yeah.
Yeah, I think we're going to transition this over to Matt. Before I transition it over to him to manage the Q&A, you all talked about different ways in which you're advocating and how you're engaging. And I think if individuals on this webinar today are interested in also having their voice heard, Royal Minds and the Grange have worked together to put together a letter that you can send to your member of Congress, asking them to advance comprehensive reforms that would protect patients and pharmacists like Alfred and physicians like Dr. Maddie. So we'll make sure that we share that information with you after the webinar, but please, consider having your voice heard. With that, I'll pass it over to Matt Duckworth, who's going to manage the Q&A portion. Keep sending those questions in if you have more. Thank you, guys.
Well, thank you so much to Jessica, Dr. Maddie, and Alfred for helping us understand these complicated issues today. I also just want to thank all of our audience members that have joined us for today's webinar. Certainly an enlightening topic, one that's not only relevant in the context of the everyday lives of patients, but also what's going on in Congress. And we're going to talk about that in the Q&A here in a moment. I'm going to be moderating that audience question and answer portion of our webinar. But first, I just want to reinforce what Jessica mentioned, which is following this conversation, you'll be receiving an email with a recording of today's event, a link to the video that we saw at the top of the webinar, and a link where you can identify your members of Congress, and you can view message content that you can then personalize and actually send your own outreach to your lawmakers in the U.S. House of Representatives and Senate, asking for their support of bipartisan reform. Both parties are in support of this on Capitol Hill to the pharmacy benefit manager industry. With that, we have a few audience questions for our panelists that are already in the queue. And some of this I think we've covered, but it bears reinforcing. Dr. Feldman, here's one for you. If PBMs are supposed to save patients money, right? That's the whole idea with them existing. Why, again, are they choosing the highest priced drugs for formularies?
It's very, very simple. The higher the price of the drug, the more money the PBM makes. So consequently, why would they choose a $300 generic when they can choose a $10,000 brand? And it's unfortunate that, it's very, very opaque. It's a big black box. Most people wouldn't even know that there was a $300 generic out there. So it's unfortunate. And anytime you try to regulate them and say, no, you can't do that, they keep doing the same thing. They keep saying that same thing, but we're saving billions of dollars. And they never really say for whom. Sometimes they'll say the healthcare system, but they are the healthcare system. So yes, there's a perverse incentive in the United States for PBMs to choose the higher price drugs because they make money on the list price of the drug. There are a couple of bills that are called delinking bills, meaning if they cover a $5 drug or they cover a $5,000 drug, how much they make would be delinked. It would have nothing to do with the price of the drug. And that is a piece of legislature that needs to pass. So there's no longer this incentive to choose higher price drugs.
Agreed.
Such an interesting kind of broken market that we're seeing, and it seems like such a common sense way to reform it through those bills that I know are out there. Another question from the audience. We've heard a lot about how PBMs are abusing the system, especially those kind of big three vertically integrated PBMs that Dr. Maddie described. The question is, are there any good PBMs out there? Alfred, I know you talked about the one good PBM that you knew about. Dr. Maddie, were there ever or are there currently any PBMs that kind of follow that mission of actually bringing costs down through negotiation?
There are, when PBMs first started, they were the ones that just adjudicated the claims, figured out how patients would pay for their drugs. They really didn't decide what the formularies were. So particularly in what are known as the employer funded plans, where the large employers or even not so large employers actually pay for the health insurance. And there are PBMs that are coming out that are, some are good and some are not so good, but they're transparent PBMs, where any money they get to save, that would bring down the cost of the drug actually is transmitted to either the employer or their employees. So they get the benefit of the rebates, and these third-party administrators, transparent PBMs, they'll make their money just on a straight per member per month basis. So they're out there, but if you're a big employer or you're someone who works for a big employer, a lot of these big manufacturing companies, you don't have any choice over who your employer uses. And the big three PBMs pull the wool over their eyes and they say, oh, if you choose one of these transparent PBMs, those drugs are going to cost you a lot more. So there's a lot of education, but yes, they are out there. You just have to know where to find them.
And it just feels like if the system could be that way for others in healthcare delivery, that we could actually realize a lot of savings, especially at the pharmacy counter for patients, which I know what some of the reforms being proposed in Congress are looking to do. I know we talked about this a little bit, but another question I think just to sort of level set is, can you talk a little bit more about what prescription drug rebates are and how do they lower prescription costs, or do they at all?
Yeah, I don't think they do. So I first heard of a rebate, you'd go to whether it was Office Depot or one of those, and you'd buy ink for your computer and you'd keep your receipt and you'd send it in and you'd get a $5 rebate. So it would be money you get back after you buy whatever it was. It's called a rebate. Well, that's sort of what it is with the PBMs. They buy the drug, or at least pay for a drug, and then every time a prescription is filled, the manufacturer gives them a kickback. Now, if Al were able to took kickbacks, or if I took a kickback, it would be illegal and we would be fined or put in jail. But they can get these kickbacks. Basically, it's what they get from the manufacturer for every script that's filled. So the more scripts they fill, the more money they get kicked back to them. Kickbacks that are often hidden and now called fees. So, but again, if we didn't, in our wisdom as a country, give them safe harbor from the anti-kickback statute, which the country, I guess, thought this would be a good way to bring the prices of drugs down. So let's let them get a kickback, and I'm sure that they'll be generous and spread that kickback with everybody else. But unfortunately, they haven't. Right. And they say they do, but they don't. And now they've actually got little companies that they've started two of which the PBMs are in Europe, where they hide the kickbacks. So now if we in the United States pass rebate transparency, they can say we pass 90% of the kickbacks that we get, but they forget to tell you that they may only get 20% of what their company in Europe is holding on to. So they pass 90% of the 20% that they get from their black box in Europe. It is just, no matter what we try to do, they pop up somewhere else. It's the old whack-a-mole game.
Yeah, it's a game they play. I've yet to see a rebate in my pharmacy.
No rebates for you,
Never.
huh?
Never.
No.
Alfred,
My
speaking of
patients don't get rebates either.
Yes, yes.
Alfred, speaking of the pharmacy counter, I think this is a good question from the audience for you. Someone is saying that their insurance company continues to pressure them to use mail order pharmacies for their prescriptions. They'd rather go to a local pharmacist. Is it as easy as them just choosing to go to a local pharmacist still? Can they do that? Or is the reimbursement model set up in a way that you may not have the drug, or like you said, you're going underwater?
Right. Well, yes, they can. Most mail orders will give you an option, but not all of them. Some will, you can only fill 2 prescriptions, and then you have to go to mail order. Or some you can only get acute medicines, and then you have to go to mail order. And it all depends on your PBM, whether or not you can get prescription drugs at the retail rather than the mail order. So you have to ask, can I do this? You have to ask your PBM or your insurance agent, can I do community pharmacy, or do I have to do mail order? And they'll tell you, and we have no choice ourselves. The worst thing for us is the patients that have come to us and said, I don't want mail order, but they've sent it to me anyway. And I don't know where they're getting their names or where they're getting the information about their drugs, but they're just basically stealing the patients. The patients don't like it, and I don't know what would do to stop it. And
Al, I have a question.
That's lately.
Do they
Sorry.
still have, I still have pharmacists telling me that they're still not allowed to tell patients that they can get a drug at a lower price, like a gag clause. Do they still have those in some areas?
Mm,
And they've worded it like, well, what you're doing is disparaging the PBM, and in the clause is there's a non-disparagement clause, so they get around the gag thing. I mean, because
Right,
it's hard
because
to
there was
believe.
reform on the federal government side around eliminating pharmacy gag clauses some years ago now, but you
right.
But I can tell you there are pharmacies that still, there's an issue. I mean,
Yeah.
the fact that pharmacists at some point prior to a few years ago across the country couldn't tell patients. I mean, and that was coming from the PBMs.
Mhm.
That just goes to show you, they don't really care about the patient at all.
Right. Yeah.
I'm going to combine 2 questions. Oh, go ahead, Alfred, please.
I'm sorry. I just don't know the answer to that question.
That's okay.
Yeah, that's a great question, and obviously one of concern if you can't access a medicine at a cheaper price when it exists right in front of you. I'm going to combine 2 audience questions here and say one, and I think we've touched on this a little bit, talking about sort of in concept the bills that are going through Congress that both Alfred and Dr. Maddie have mentioned. What is the federal government doing about this and reining in the abuses caused by PBMs, not only in Congress, but with the FTC, for instance? And then 2, on the state side, are the states able to pass laws or help regulate actions by PBMs, or is it just the federal government?
Well, obviously, my
Yeah,
state
go
can
ahead,
do it.
Al.
I'm sorry.
Go ahead.
Obviously, my state can do it because they did it. And Kentucky is I'm proud of our legislature. Really.
Yeah, the Kentucky, I think they found millions upon millions of dollars that was being stolen from Kentucky, I think
That's
through the
right.
Medicaid program, the PBM. Yeah.
But now the federal government, they're looking at it. That's all I can say about that.
There are a number of laws already passed, as I said, in the states. The problem is when a piece of legislation is passed in the state, it only covers certain groups of insurance. It'll cover like the kind of insurance I offer to my employees, and it might cover the exchanges. But it seems like now people who work for these big companies, state protections don't apply to them. It has to be passed by the federal government. So there is something called the Safe Step Act, whereas if you live in a state that has passed step therapy reform, but you work for UPS, you're not going to be able to get those protections. But if the Safe Step Act would get passed, there's the potential that what we call the ERISA plans, or the self-insured plans, those patients would get the protections. It's funny because they always talk about ERISA protections. Well, those patients are certainly lacking, that kind of protection. And then there are bills out there to protect the pharmacists in terms of anti-steering, in terms of those DIR fees, a lot of things out there. And I'm sure they can send you, to areas where you can look at these and perhaps contact your representative. The delinking is really important. If we could pass that along, and then also PBM pass-through, rebate pass-through. It may not pass through all the way to the patient, but it might pass to their employer, which could then lower premiums. So any kind of pass-through to anybody else, I think, would be good. Although unfortunately, a lot of times, particularly with the Part D, if there were pass-through for Part D, it would probably go to the, to the mothership. So it might go from, Express Scripts to Cigna. But you've got to start somewhere. So rebate pass-through, delinking, and then, of course, a lot of the Buddy Carter, who's the pharmacist who's in the House of Representatives, he's a champion for a lot of the reforms that to help pharmacists as well. Community pharmacists essentially stay in business.
Yeah. Well, as far as I'm concerned, as a rural community pharmacist, the DIR fees and the steering are the most important right now, in getting people not to have to go to mail order, or to go to a pharmacy that's preferred on their PBM plan. And the DIR fees are just killing us. And of course, that's only on Part D. So we don't want to make sure that we understand that that's a Part D plan for retired people that's hurting us. I'm talking about a couple of $100,000 for my little store. And when you figure in, like, Ozempic probably runs about $1,000. So I have to buy that Ozempic. I have to put it in my store, and when I'm making minus $10 or plus $10, then I have to wait 15 to 30 days for my money. It's not worth it for me to fill it. So but I do respect my diabetic patients. I need to fill that because I need my diabetic patients to get their medicines. So we do. And it's hard for us to do that.
Yeah, all such good points and such good topics. I know we are at time today. So as we close out the question and answer portion of our event, I want to remind everyone just to keep an eye out for a follow-up email with the recording of today's webinar, and especially to utilize that email template to personalize your message to Congress on these important issues. You can request their support for bipartisan PBM reform in any upcoming legislative package through the end of the year. On behalf of Rural Minds and the National Grange, I first want to thank Dr. Maddie and Alfred for taking so much time with us today and sharing their expertise. And again, I want to thank everyone for joining us for the webinar. I hope you all have a great day.